Ladies and gentlemen, so I'm Raj Gupta, one of the neurology consultants who works at Birmingham Children's Hospital. I've had the pleasure of meeting you and examining a lot of you in the paediatric clinic. And I also need to apologise, like Tim did, for being late. You know, because you were supposed to have heard me this morning, but now it's the afternoon, so apologies. So what I want to do today is talk about the neurological aspect of Wolfram syndrome. Now, unfortunately, we seem to know about a lot of neurological problems that you can see with Wolfram syndrome, but we don't necessarily know why you see them. Okay, so I'm just going to talk through them. This is going to be informal, and if you have any questions, I'm happy to take one or two questions during. Otherwise, you can speak afterwards. So, just a brief summary of the background. We all know that Wolfram syndrome is very rare. And we're learning more and more about Wolfram syndrome. The fact that we now have social media and better communications across the world, I think we're actually learning a lot more about Wolfram, learning a lot more things more quickly compared to before because of better communication. As Tim mentioned this morning, Wolfram syndrome was first described in 1938. We know that it's an autosomal recessive condition, and we know that it's characterized by insulin-dependent diabetes mellitus, optic nerve atrophy, diabetes insipidus, deafness, and other neurological issues. We know it's caused by WFS1 gene, and we know that you basically, as a result of mutations in that gene, have problems with the endoplasmic reticulum, and then you get stress-mediated cell dysfunction and death. So the eye manifestations are characteristic of Wolfram syndrome. And what you see is you get optic nerve atrophy, so that basically means that the fibers in the optic nerve which basically connect the back of the eye to the occipital lobe where information from the eye is interpreted into vision doesn't work properly. And that's why you get the vision defect associated with Wolfram syndrome. What we also know is that some patients can actually develop cataracts, and that's where you get clouding of the lens. So, when you go to eye clinic, you know we shine the ophthalmoscope into the back of your eye. So what we're trying to look at is to see what the back of your eye looks like. And that part is called the fundus. And the diagram on the right basically shows a nice red circle. That's what we're hoping to see. And then you see a more yellowy tinged smaller circle on one side. So that yellowy tinge is basically where the optic nerve enters the back of the eye. Now, what you get with Wolfram syndrome is atrophy of the optic disc, so that yellowness becomes a pale yellow color. So the picture on the right shows a slightly pale optic disc. Now, it can be that subtle, but often with Wolfram syndrome, it's much more noticeable. So you actually lose the yellow color, and it becomes quite white in color. So that's one of the hallmarks of Wolfram syndrome. Now, you can also see on MR scans that there is optic nerve atrophy. So this is an MR scan. It's a coronal view, and it's basically going through the eyes. You can see the front of the brain here, and you can see the eyes there. And these are the optic nerves, and you can see that they look quite small. And this is another view. So this is coming across this time, so we're seeing from the top. So in this picture, you can see that the optic nerve is this thing here. It's quite thin. And if you compare it to the normal optic nerve, you can see it's quite a lot thinner. Agreed? So basically on the MR scan, the optic nerve also looks thinner, and that just basically confirms what we're seeing when we look at the back of the eye. And this is just a picture of a young lad who's got a cataract. So you'll see that on the right eye, it's got a white cloudy look, whereas on the left eye, it looks perfectly normal. So this child hasn't got Wolfram syndrome, but it's just a picture to sort of demonstrate what a cataract may look like. And what you're also aware is that a lot of us, the older we get, start developing cataracts. So you'll find that in the normal population, a lot of the older folk will end up having surgery for their cataracts. As well as the optic atrophy and vision problems, another major neurological symptom and sign of Wolfram syndrome is hearing loss. What we know is that it's sensory neural hearing loss, so again it's due to the nerve function, and it affects about 70% of patients. And the hearing loss, it initially impacts on the high frequencies that we hear compared to the low frequencies, but as time goes on, the lower frequencies may also get affected. So this is a diagram of when you have your hearing assessment done, a pure tone audiogram, and the red dotted line is where the normal threshold should be from low frequency to high frequency. The different colours represent the different ears, so right ear and left ear, and you can see that there's a dip at the higher frequency end. So that's the common type of pattern that you see with Wolfram syndrome and hearing loss. Now, the Wolfram syndrome clinical management guidelines do talk about the need to carefully assess vision and hearing. Okay, so what they suggest is that there's different ways of actually looking at the eye. So as well as just looking with the torch, with the ophthalmoscope at the back of the eye, you can do some fancy tests to try and get a better idea of how thick the retinal layer is, for instance. You can do OCT with that. It's important that you obviously do the appropriate visual acuity assessments. You can do colour vision as well, and they all give us an idea about how good or how bad the vision is. And obviously, it's important then to put in the right types of treatments to try and overcome that as best as possible. Okay, so in school and college, making sure that you have the involvement of the vision impairment team, that you use a whiteboard, you have a personal whiteboard, maybe use an iPad to try and magnify things better. But it's important that these things are put in place, because ultimately that will help you to do as best as you can at school and college. And if you do as well as you can at school and college, it'll also help you from a psychological point of view and make you feel normal, in inverted commas, doing what you think everyone else is doing. Same goes with hearing. Hearing, you need regular assessments to see what's happening. With regards to how good your hearing is, you can do some fancy tests, audiometry evoked potentials, for instance. And again, there are treatment options available, so hearing aids and potentially even cochlear implants. Okay, so again, these are things that we can actually help support so that the impact of these things is less than they would be otherwise. Now, when we look at MR scans in Wolfram syndrome, there are two other places where we are always looking. Okay, one is looking at the brainstem, and we had some discussions about brainstem issues already in the previous workshop. So the brainstem is basically the connection between the brain and the rest of the body, and so all the impulses go down there. Now, the brainstem also contains the automatic functions, things that we take for granted that we don't have to think about, such as breathing, such as our heart beating, also the way that our gut works. And what we know that can happen with time with Wolfram syndrome is that you get brainstem atrophy, so the brainstem shrinks in size. And that in turn leads to a lot of the problems that we see, particularly as you get older with Wolfram syndrome. The other part of the brain that we always look at is the cerebellum. So the cerebellum sits right at the back, around here, and that helps to control balance and coordination. So when you come and see me in clinic, I get you jumping and hopping and all that type of thing. And that's basically giving me an idea about how good or not your balance is, and that in turn gives me an idea about how your cerebellum is working. So let's talk a bit about the cerebellum. So this is a nicer picture of the brain, okay? And the cerebellum is this bit at the back. It's quite a complex structure, but as I said, it has a massive role in everything that we do. Because if you think about it, most things that we do, you need to have good coordination, good balance. So again, things that we would normally take for granted. So swallowing, for instance, is quite a complex process to swallow safely. And the cerebellum helps to control that, helps to coordinate all the muscles of your swallow. Even breathing to some extent. When you're speaking, to make sure that the words sound right, everything flows nicely. That's your cerebellum working again. And also with regards to movements that you do. So there are various tests, signs and symptoms that we look at when we're trying to assess cerebellar function. So one is nystagmus. We look at the eyes to see if you've got some jittery movements. That can be a sign that your cerebellum is not working properly. We call it nystagmus. As I've already mentioned, you may have speech difficulties and you may have swallowing difficulties due to poor oromotor control, so poor control of the muscles around your mouth and throat. You have dysdiadochokinesis. Okay, now dysdiadochokinesis is just a posh word for something relatively simple. So in clinic, I'll have got you to put your hand out and then clap and turn your hand back up and down as fast as you can. So that's quite complex to do. And your cerebellum's helping you do that. If you have problems with your cerebellum, trying to do that smoothly becomes more difficult. And it's difficult to coordinate as well. The other thing that I get you to do in clinic is touch my finger, touch your nose. All right? So again, I'm trying to find out whether you might have a tremor. So as you approach my nose, or as you approach my finger or your nose, you might find that there's a tremor developing. And also what sometimes happens is that you tend to overshoot your target. So instead of getting my finger at the tip, you may end up going past my finger. Or instead of touching the tip of your nose, you might go to either side of your nose. Again, that might be due to your cerebellum not working as well as it should. And the other thing I spend a lot of time doing is just watching you walk. Okay? So if you have problems with your balance because your cerebellum is not working, you're going to try and walk in a way that makes you less likely to fall. And the best way of doing that is actually you keep your feet apart. You have what we call a wide base gait, because if you've got a bigger foundation, you're less likely to fall over, as if you keep your feet together. All right? So people with cerebellum problems often will walk with their feet wide apart, and they're slightly unsteady still, because they have to keep on trying to make sure that they've got the right balance. So, and the last test that I often get you to do is stand still with your feet together, and then ask you to close your eyes. Okay, that's because the vision that you do have also helps you to stay upright. And if I take that vision away from you, by making you close your eyes, you often become more unsteady. All right? So I just want to see how much of a difference having your eyes closed makes to your balance or not. If you close your eyes and you still maintain good balance, that gives me a good idea that your cerebellum is actually working quite well. Okay? So this is a video of a young lady, hopefully it'll work. And it's basically showing the eye movements that she's got. So she's got jittery eye movements from left to right, affecting both eyes. That's what we call nystagmus. All right? And then I've got this video off YouTube. YouTube is great, actually, with videos. So this is a chat from the States, okay, with a doctor. Say that again? I should reference them, shouldn't I? So hopefully this will work. It says. Maybe not.
Okay, walk a little bit.
So it shows basically this man with cerebellar signs, and he has difficulty with maintaining his balance when walking. So as I described before, he's basically walking with his feet apart, and you can sort of see that he's actually trying to correct the way that his body is kept upright. So he tends to slouch forward, because it's easier then to help him maintain his balance, and every so often he's correcting. Okay, turning around is more complicated. Okay, because he has to sort of work closely and make sure that he is able to maintain his balance as he is rotating. And then even coming to a halt, trying to stop suddenly can be difficult. And again, I've done some complex tests with some of you where I get you to walk and then I suddenly want you to stop and do a swivel and turn around. Again, I'm trying to see what your coordination and your balance is like, how your cerebellum's working. Now, we'll talk a bit about the brain stems. I've already told you that the brain stem tends to show atrophy with Wolfram syndrome. Now, the brain stem controls the flow of messages between the brain and the rest of the body, and it controls the basic body functions that we take for granted, such as breathing, swallowing, heart rate, your blood pressure, even your consciousness level, and also whether you're feeling tired or whether you're not feeling tired. And what we do know is that with brainstem problems, you can get problems in all those areas. You may also get pauses in your breathing, so you can actually get sleep apnea, where suddenly you basically just stop breathing. And often that's just momentary, but enough to cause your oxygen saturations to drop. And that again will then impact on your quality of sleep, and then may also impact on the way that you are able to behave and do things the next day when you're awake. But we also have to bring into account diabetes. Diabetes mellitus itself can cause problems with the way that your nerves work. So individuals who don't have Wolfram syndrome but have diabetes mellitus can ultimately also develop neurological complications as a result of their diabetes. Now, the most common issue is diabetic neuropathy. Now, we're not 100% sure why you get nerve sickness from diabetes, but the general feeling is that the diabetes can damage the very small vessels which supply the nerve, and when you basically damage the vessels that supply the nerve, you don't necessarily get enough oxygen and nutrients to the nerve, and the nerve then also gets damaged. And what we also know from our studies on patients with diabetes mellitus is that tighter control, so the better your blood sugars are controlled, the less likely you are to develop diabetic neuropathy, or the less likely you are to develop severe diabetic neuropathy. So one of the key issues for all of you here is trying to ensure that your diabetes control is as good as it can be, but also not so tight that you're having hypoglycemic episodes, so that's not good either. And the diabetic neuropathy may affect your nerves in your arms and legs, we call that peripheral neuropathy, but it may also affect your autonomic nervous system, which we call autonomic neuropathy. So the most common type of diabetic neuropathy is peripheral neuropathy. And usually your feet are affected more than your hands. But you'll find that you may start developing problems with numbness or tingling sensations, sometimes pain, often in your hands and your feet. And with time it may extend up your legs or up your arms. So it may follow what we call a glove and stocking distribution. And what you sometimes also find is that these symptoms of numbness, tingling, pain, etc. are worse during the night, or potentially worse when you wake up in the morning, and then seem to improve again. So this is just a list showing symptoms of peripheral neuropathy. Okay, so symptoms of the nerve sickness in your arms and legs. So numbness, reduced ability to feel pain, or even temperature changes, so your hands might always be cold, for instance. You may get tingling or burning sensation at the tips of your toes or tips of your fingers. You may get sharp pains, which can be quite distressing, or you may get cramps, which are distressing. Sometimes your arms and legs just feel oversensitive, so even bed sheets, for instance, just seem to cause you a lot of discomfort. You may also get problems with your muscles, because obviously your muscles need the supply of the nerves. So if your nerves aren't working properly, that may then mean that your muscles don't work properly. So you may get what we call a myopathy, some weakness of your muscles. And then signs that I'll be looking for in clinic would be obviously testing your sensation. So often I get to close your eyes and say, tell me when you feel me touching you. Okay. Also sometimes I check your proprioception. Alright, so that's basically I ask you to close your eyes and then move your finger on your toe up and down. I ask you to tell me which way it's pointing. Okay, because that tells me that you're getting sensory feedback to yourself, to your brain, to sort of tell me then which way it's pointing. And obviously, if you've got problems with the way that you perceive pain, so if you're not perceiving pain as much, you're more liable then to sort of develop injuries to your fingers and your toes, particularly your toes. So one of the things that we should be doing as a regular diabetic checkup is looking at the condition of your feet to check there's no ulcers developing there, because you may have ulcers or damage that you're not aware of unless you go looking at your feet. So one of the things I think you will have been told is to examine your feet regularly, just to check that you're not developing any sores, etc., that you're not aware of. Because obviously if you leave them unchecked, they can get quite nasty. So let's talk a bit about the autonomic nervous system. So that's part of the nervous system that supplies the internal organs, including your blood vessels, stomach, intestine, liver, kidneys, bladder, heart, so on and so forth. It also supplies your salivary glands and also your sweat glands. So the autonomic nervous system basically works without us having to actually think about doing it. This is an automatic nervous system and it controls all these bodily functions that we have. So very briefly, there's two divisions of the autonomic nervous system, parasympathetic and sympathetic. So the parasympathetic division is basically our resting state. It basically helps us to do everything that way we're relaxed, okay? Whereas the sympathetic basically causes heightened activity of things. It produces that fight or flight response if you're scared, for instance. So it basically gets you prepared in that sense. So the parasympathetic is more relaxing, whereas the sympathetic is now you've got me confused, now you're checking it out. Okay, whereas the sympathetic system basically creates more activity. So signs of autonomic neuropathy can include problems with maintaining blood pressure. So for instance, you get up from a lying position to a standing position, it may take a while for your blood pressure to adapt. So when you get up from sitting or lying to standing, your blood pressure should stay the same or increase a little bit. But what you might tend to find is that it drops a little bit. You may have problems with the way that you sweat. You may have too much sweating, or you may have too little sweating. It can also affect your gut, so you can get constipation. You can also get slow emptying of the stomach, so gastroparesis. And you may have also issues with your temperature control. And obviously we can manage your gut by actually thinking about medications to stimulate the way that your gut works, for instance. We may also think about changing your diet. So if you can't tolerate a large quantity of food at any one time, then you basically reduce the quantity of food and have it more frequently. Headaches are common. Headaches is the commonest neurological condition that we see in clinic. Okay, so headaches affect everybody, including individuals potentially with Wolfram syndrome. But most headaches that we tend to see are the migraine or tension types, but with Wolfram syndrome you may also get neuropathic pain, and that's quite painful neuralgia affecting the face. And again, there are treatments available, medication treatments available for that. I'm going to briefly talk about epilepsy. So epilepsy is basically a disturbance of behavior, motor function, sensation, or emotion, and it's triggered by abnormal activity, excess activity on the surface of the brain. And we allow everybody to have one seizure before diagnosing epilepsy, but if you have two seizures, we then call it epilepsy. Epilepsy is common, or relatively common. About 1 in 100 to 150 people in the general population have epilepsy. What we also know about epilepsy is that this is epilepsy in the general population, not necessarily epilepsy in Wolfram syndrome, but it's very common in the very young, not so common in middle age, but then increases in frequency in older age. And the reason it increases frequency in older age is because our brains are generally degenerating. Okay, we start developing scars on our brain, whether that be due to mini strokes or maybe even due to tumours. Okay, and then that acts as a focus for the seizures. There are many different types of epilepsy. There are two main types that you need to sort of think. So this is the way that we differentiate epilepsy. We talk about generalized epilepsies. This is where you have the abnormal activity affecting both sides of the brain simultaneously. And with generalized seizures, you tend to get severe impairment of conscious level or loss of consciousness. And then this is a video of somebody having a generalized tonic-clonic seizure. This is the type of thing that you might see when you're watching Casualty, for instance, or Holby City. Okay? So everyone understands a generalized tonic-clonic seizure. You lose consciousness, you have stiffening, you have jerking, you have drooling of the lips, etc. And eventually it comes to a halt. But you can also have other epilepsy types, and the other main type is focal.
Excuse me.
Yes?
Me and my sister have nocturnal seizures.
Yeah.
We're always asleep when we have our seizures.
That's right. So there are a lot of epilepsy syndromes where you can only just have nocturnal epilepsies.
Yeah.
And I'm going to talk about that a little bit. So I'm talking about focal epilepsies now. So focal epilepsy is when the abnormal activity just impacts on a particular part of the brain on one side of the brain. So it doesn't do both hemispheres simultaneously. And with these, you tend to have some consciousness. Okay, so you have some awareness of what's going on. And these types of seizures often occur during sleep. Okay, so sleep onset seizures are often focal. And you may get disturbances in your motor function, so you may get some jerking with it. You may be fully aware, but have a feeling of butterflies in your tummy, or an odd taste in your mouth, or a smell of burning. Or you may have a combination of both, some twitching plus these sensory aspects. Now, depending on where the abnormal activity is arising from, that actually determines how that seizure manifests. So this is just a diagram of the brain, looking at the different parts of the brain, and showing what types of manifestations you might get as your seizure as a result. So the back of the brain, the occipital lobe, that's our vision cortex. So even though the eyes are at the front of our head, the analysis of the information that comes from the eyes is at the back of our brain in the occipital lobe. So if you have occipital lobe seizure, you tend to see colours and patterns, maybe flashes of light. Our temporal lobe, obviously that takes information from the ear, so you often get auditory hallucinations, but you can also get visual hallucinations from the temporal lobe. And the other thing with temporal lobe seizures is that you often feel frightened. So these individuals, if you see them have a temporal lobe seizure, will often look frightened. And then just the frontal lobe is where our motor cortex is. So the frontal lobe basically has a strip of brain that helps to move our arms and our legs. So frontal lobe seizures often present with abnormal posturing of your arms or legs. So this is a video of a young lad who's having a temporal lobe seizure. Hopefully it'll come on. Alright, that doesn't play, but I can show you that later. Now, as well as epilepsy, we know that psychological manifestations of Wolfram syndrome are very common. Anxiety and depression are common. You may rarely have psychosis, well, that basically means when you have an impaired relationship with reality, so that may include things like hallucinations and delusions. But what is interesting with Wolfram syndrome, we touched this on the workshop, is that cognitively, with Wolfram syndrome, you remain very good. Okay, so you don't tend to have issues, particularly with your learning abilities or your attention and concentration. And again, there's a Wolfram syndrome treatment guidelines, and it basically looks at all the things that I've talked about. So assessing cerebellar function, for instance, assessing brainstem involvement, looking for peripheral neuropathy, taking a history for epilepsy if there is epilepsy, and also obviously cognitive and psychological assessment. So when you come to clinic, these are the types of things that we're all doing. So in conclusion, Wolfram syndrome is a multi-system illness. It affects different organs of the body. Neurological signs and symptoms, in addition to the eye problems and the vision problems, the eye problems and hearing problems, are relatively common. It's important to maintain good diabetes control, because obviously diabetes in itself can cause neurological problems, neurological complications. There are symptomatic treatments available which basically will help to relieve these symptoms that you have, and that in turn will then help you to have a better quality of life, which is obviously the most important thing. Now, because it is a multi-system illness, it's important that there's input from many disciplines. Doctors, other health providers, but also therapists. Physiotherapy and occupational therapy, the vision impairment team, etc. are extremely important. Now, unfortunately, the way that the NHS is with resources, these things aren't always necessarily offered to you. So it's important, as I'm sure many of you know, to keep pushing and asking for these things. Any questions? Let me just show you that one video, if it works. Yeah, that might work. We'll give it one go and see what happens. That's the one video. But I'm happy to take any questions while this might play. I think it's quite a useful video to see, because it shows this child who's actually very frightened because of his epilepsy. And he's actually hallucinating, so you can see him looking around as though he can see monsters or insects. Okay?
Birds flying over there.
That again?
My ex used to have epilepsy and she used to crouch down
Yeah.
when it was coming up.
Yeah.
Birds flying around
That's
the
right. So that's likely to be temporal lobe epilepsy. This video doesn't want to play, so I'm going to leave it there.